So let's get to the second part of the presentation, and the title of that is Restoring Symmetry of Hearing in Adults and Children with Unilateral Hearing Loss. Unilateral hearing loss or single-sided deafness is the type of impairment where there is normal hearing or near normal hearing in one ear and impaired hearing in the other ear. There are multiple causes: trauma to the head, excessive noise exposure in one ear. There are genetic or hereditary issues, specific syndromes, various illnesses, and anatomical variants. Hypoplastic nerve, no cochlea, hypoplastic cochlea. So these are issues that we have particularly with children, which we'll talk about in a few minutes. They're often unknown, so we have a lot of adults with idiopathic sudden sensorineural hearing loss. The symptoms might be head noise or dizziness. They wake up in the morning and they've lost their hearing. So what about the incidence of unilateral hearing loss? Well, there's 3% of school-age children are affected, and there are 60,000 new cases of SSD identified every year, so it's a bit of a problem. Are two ears working independently? Are they important? Well, we think they are very important. There are potential advantages of two ears. We think the ability to hear sounds on both sides of the head. We think the ability to locate sound in the environment and improved understanding of speech are three of the most, in background noise, are three of the most important potential advantages of two ears. What are the psychoacoustic reasons for this? Well, there are three reasons. One, and the most important one, is the head shadow effect. And that's the benefit from adding the ear with the more favorable signal-to-noise ratio when listening in spatially separated speech and noise. So if I have a normal ear on my left side and there's a lot of noise on my left side, I really should be using my right ear because it's in a more favorable signal-to-noise ratio. So the head shadow effect actually gives us a mean improvement of about 10 dB in what we call the signal-to-noise ratio, which is 10 dB is huge. So the head shadow effect is the most important psychoacoustic variant. Binaural redundancy, we know that two ears are better than one when listening to speech in quiet or in noise presented from the same location. And the binaural squelch adds about 3 dB improvement in signal-to-noise ratio. And that's the benefit of adding the ear with the less favorable signal-to-noise ratio. So those three psychoacoustic phenomena work together to help us to hear better with two ears as opposed to one. So what are the current treatment options for single-sided deafness? Well, the first is traditional amplification, maybe a power hearing aid on the off side in the hopes that it can give the patient some benefit, or even cross over to the better hearing ear and be a power cross, as we would call it. Or a regular cross-hearing system. We know there are a few manufacturers now that are making cross systems, and that's a possibility for a patient. Of course, there's no surgery, and hearing aids are returnable, so often a hearing aid is a reasonable first option for a patient. You certainly want to go from least invasive to more invasive when you're trying to think of a treatment option for SSD. Other non-surgical solutions are the nucleus or cochlear sound arc, the Med-L Adhere, or a soft band for young children. So the Adhere from Med-L, I think, is a pretty ingenious, innovative way for things to work. What it involves is an adaptive adhesive adapter that goes onto the skin onto the mastoid, and then you snap on an audio processor. And we've had some success at NYU with the Adhere, so I think it's a great system. I think it's been around about a year and a half or so. And it's been working very nicely as a non-surgical treatment for SSD. Then there are osteo-integrated bone-anchored devices, percutaneous devices like the Oticon Medical Ponto, the Cochlear Baha Connect, and then there are transcutaneous devices, the Cochlear Attract, and Cochlear just came out with something called the ASIA. And the ASIA is a system that represents a new type of bone conducting system that uses digital piezoelectric stimulation to transmit sound directly into the inner ear. And so this is what it looks like. It looks very similar to a cochlear implant, but is for patients with single-sided deafness or conductive issues, for patients who can't wear a conventional air conduction device. This is what it looks like. At NYU, we've done 5 patients. We have some data on 1, and so far the patient seems to be doing very nicely. But all those solutions, all those treatment options, although they do offer a solution, they don't provide the benefits of binaural hearing, which is localization ability, hearing and noise, and naturalness of sound, since the sound is directed from the poorer ear to the better ear. So various investigators actually in Europe have talked about cochlear implants for patients with single-sided deafness for tinnitus suppression, because we know electrical stimulation can reduce tinnitus. So that's where it started first. They have many, many more patients in Europe, at least they did, than we do, because they were doing it for tinnitus suppression. So what happened over the last several months is MED-EL was able to get FDA approval for single-sided deafness, which is really a great thing for all patients, because if a device is approved by the FDA, it makes it much easier for these patients to get a device through insurance. So this is a great first step. In terms of age, this is the candidacy criteria. In terms of age, the patient needs to be 5 years or older. In terms of hearing loss, there are 2 different cohorts. The single-sided deaf patient needs to have a profound sensory neural hearing loss in one ear, and normal hearing or a mild sensory neural loss in the contra ear. And for the asymmetric approval, a profound loss in one ear and a mild to moderately severe in the contra ear, with a difference of at least 10 dB in pure tone averages between the ears. In terms of speech perception scores in the ear to be implanted, the patient has to have less than 5% on CNC words and quiet, which is kind of strict. And for children, less than 5% in developmentally appropriate monosyllabic, words in quiet. Patients need to undergo a 1-month trial of hearing aids, some type of hearing aid, or some type of relevant single-sided deafness device, and make sure they don't show any subjective benefit. The contraindications for this device are very similar for what they would be for any cochlear implant patient. Plus, you don't want to implant patients with more than 10 years of profound deafness, these single-sided deafness patients. We know that length of deafness is the most important prognostic indicator for any cochlear implant. So for this particular approval, they didn't want any patients with more than 10 years of profound deafness, which makes perfect sense. So the next 3 or 4 slides, or 4 slides you're going to see, are courtesy of Meg Dillon. Dr. Dillon is the head of research at audiology at UNC, and she's done a lot of groundbreaking work on SSD patients, and the data that she was able to accrue and present, I think was partly due to the approval of MED-EL with the FDA. The patients she used were MED-EL patients. There were 20 adults with a moderate to profound sensory neural hearing loss, with a mean duration of hearing loss of 3 years, with a mean aided CNC score of 4%. The patients had normal to near normal hearing in the contra ear, and the mean age of implantation was 50 years. So as you can see, these are patients. This is a speech recognition and noise on AZ Bio. I believe the signal-to-noise ratio was 0. Along the y-axis, we see present correct. Along the x-axis, we see position of the noise. And as we can see, the patients were tested preoperatively at 1 month, 3 months, 6 months, 9 months, and 12 months. And we also have normative data up here. So when noise was at the good ear and the patient was left to hear with their poor ear, we see a significant improvement when they got a cochlear implant. From pre-op to 1 month, there's a significant improvement, and they actually continue to improve over time, which is great. When the speech and the noise are together, we see pretty typical, very close. There's not much of a difference between pre-op and post-op, which makes a perfect sense. And when we see the noise on the bad side, we see a ceiling effect. So getting back to the first pain, we see a significant improvement from pre-op to 1 month, and that makes perfect sense, and that's great. In terms of localization, we see this is the root mean squared, which means better is lower. Preoperatively, the patients are up here. From the pre-op to 1 month, we see a significant improvement, and that improvement holds significant through the first 12 months. And of course, this is a patient's performance for normal hearing patients. This is the tinnitus handicap scale. As I said before, we know that patients have reduced tinnitus with electrical suppression, and there it is. Preoperatively, tinnitus severity is lower. These are patients who complained of anywhere from moderate to greater tinnitus on the tinnitus handicap inventory, and you can see there's a significant improvement from pre-op to 1 month, and it even gets a little bit better at 12 months. So over time, tinnitus is suppressed in these patients. If the SSQ, the speech, spatial, and qualities of hearing scale, shows a significant improvement between pre-op. This is the general total score, and these are the speech, the spatial, and the quality scales. And we can see from pre-op to 1 month, there's a significant improvement, and from 1 to 12 months, there continues to be an improvement in overall. And if you look at the separate subcategories, there is an improvement in each subcategory, which is nice to see. So we, in 2016, Dr. Dillon's study came out at the end of 2019, I think, or sometime in 2019. A few years before, we did a few patients ourselves at NYU. Dr. Friedman was the author of this, and we did single-sided deafness in kids and adults and looked at the results. And we see, in terms of demographics, 50-50 male-female, single-sided left ear, right ear, pretty much the same. It's interesting, the age of implantation in our patients was a mean of 50 years as well, and our duration of deafness is very, very similar to Dr. Dillon's, which was 3 years. These were the tests that we did preoperatively at our center, which we still do. Pre-op air and bone, admittance, MRIs, speech reception thresholds, and speech discrimination where appropriate. The adaptive hint was done. In sound field, we use some direct connect testing, which we'll talk about in a minute. We use some vertigo and tinnitus questionnaires, and I'll talk to you about the direct connect. So the direct connect is a system we borrowed from Cochlea Corporation. It's a research system. We know that plugging and muffing the normal ear in the sound field is probably not adequate, and putting masking in an ear has its difficulties as well, because we want to make sure there's no overmasking. So the best way we think to be able to test someone, at least post-operatively, well, this was actually, we were able to test them preoperatively as well with EAR plugs. So this was the direct connect. We don't use it anymore. We had some trouble with the hardware. So we'll talk about the kinds of things we think you need to be doing when you're testing your patients with SSD. This is the direct connect system. That's some old bald guy there. I don't know who he is. This is a close-up of the direct connect system. So for the study that we just talked about, this is the methods section, standard age-appropriate testing for air and bone. Speech perception measures were performed in the sound field. As I said, we used the plug and muff for the kids, but once the kids were a little bit older and it wasn't so scary for them, we might have used the direct connect method. Preoperatively for adults, in day 1, we used the unaided audiogram and aided speech perception, CNC words for the right and left ear. Day 2, the adaptive hit and sound field in 3 conditions, and then we did it with a cross hearing aid in 3 conditions. We did localization testing. We did the the hearing handicapped inventory scale, the SSQ, the tinnitus, and dizziness if applicable. This is some mean data, pre-op and 1 year, and their most recent. So this is over time. And you can see the patients go from 2% mean to 55% mean. And the AZ Bio goes from 6% to 95% to 92%. I think you're not seeing a whole lot of difference on the HINT and the BKB SYN, but as you can see, there's a significant improvement from pre-op to 1 year, very similar to Meg Dillon's results. This is just some individual data for different tests, the CNC words, the HINT or the BKB, and as you can see, you need to look at single subject data. This is showing you many of the patients do well, some of them not so well. We can talk a little bit about this during our live discussion. So what do we see? What kind of results do we see for adults? We see improved speech perception and background noise. We see improved localization ability. We see reduced tinnitus. And the vast majority of patients are full-time users of their implants. So we think that that a cochlear implant is really a viable treatment for adults with single-sided deafness who have short-term single-sided deafness. I would actually tell you that if you see an adult with short-term single-sided deafness, after they're treated medically with steroids, a cochlear implant should be the next treatment option, in my opinion. This is a study that's in press. Nicholas Deep, who is a fellow at NYU, did a study on 14 of our pediatric patients. Here, the mean age of those kids was 5 years with a range of 1 to 11. The duration of deafness was 3 years, with a mean duration of deafness from 6 months to 7 years. The etiology was variable from large vestibular aqueduct to connexin 26 to CMV to cochlear nerve deficiency to unknown. In terms of their usage, it's variable. We have kids that are wearing them all day long, and we have kids that are part-time users. Data log shows a mean of 6.5 hours a day. Performance is variable. We do have 6 out of our 14 kids that have some open set discrimination, and all of the kids have detection. One of our kids with open set discrimination decided not to wear their device, so we have an open set discrimination kid who's actually a non-user. So in terms of results for SSD kids with cochlear implants, and I should say, which I may not have, we can send you a draft of our protocol. And I will do that before we get onto our live discussion. Results for SSD kids with cochlear implants, it's a mixed bag. Kids don't do as well as adults, and the reason for that is the adults we're typically doing are short-term, idiopathic, sensory neural hearing loss. They have all the equipment, everything was going well until they lost their hearing. And they come into the clinic and they're deaf for anywhere from 6 months to 15 years. And in my opinion, they're great candidates to implant. Not so much for kids, because kids often have some anatomical variant that will reduce their ability to benefit from a cochlear implant. So as I said, significant improvement for some and minimal improvement for others. Here are some of the issues that we think of when we deal with kids. The first issue is one of counseling. We talk to the parents about the benefits of binaural hearing for home, school, and social settings. We wonder, there are a lot of questions here. Is younger better? Is compliance going to be better with a younger child? If implanting an SSD kid at 1 year of age, is that better than waiting till they're 9 years of age? We think the answer is yes, because sometimes when you realize that the child is struggling at 5 or 6 years of age, it may be a little bit too late to implant them. But it's a difficult parental decision. If you extrapolate the data from adults, we see some with SSD struggle and others don't. But you can't, as I said, we can't wait too long to make this determination in kids, because by the time you make the determination, it may be too late. Help with invisible handicap. We don't want to pathologize a child that really doesn't have a pathology or may have a minimal pathology. Now you're putting a cochlear implant on a child when maybe you didn't need to. The cochlear implant center issues, when to implant. After what duration is it too long? Is the cochlear nerve present? How much better is earlier implantation? What about the cost? These are questions we bat around all the time. Some of the pre-implant candidacy considerations, etiology is critical, right? If someone has a cochlear nerve deficiency, you need to counsel the parents about what you think the performance of this child's going to be. Imaging, we talked before in my first presentation about MRIs versus CT scans and how important MRIs are. Age of implantation is important. Parental motivation in this group is very high, so a lot of times the parents will come in wanting to get an implant, but then after they see the child's not doing well because of their etiology, motivation drops off after the implant. Certainly a trial with other devices is critical, whether it's a hearing aid, a Baha, a Cross, or any other devices I talked about. Insurance approval is difficult, right? So we have a lot of insurance rejections in this population. We've had kids or adults rejected 4 or 5 different times, and we reapply and we go back and we keep going back and we write letters, and often we get it approved. What about the evaluation considerations? The plug and muff method, we talked about that. There are times, and I presented this before, where we saw a kid from another center who supposedly was doing really very well being tested with the plug and muff method, and when they're tested with the direct connect method, they weren't hearing anything, and it turns out this kid wasn't hearing anything. The plug and muff method often is just, not for every patient, but often is just not a valid way to be able to test these kids. We need to use direct methods. So one of the direct methods I would say is putting a hearing aid in a child's ear and maybe putting a loop around their neck and testing them that way. Testing them with a microphone in on the other side of the booth with a loop and a hearing aid. I think preoperatively and postoperatively, and I may be jumping the gun now, but we use maybe a microphone, a mini mic if it's a cochlear device, and all of the cochlear implant companies have ways to use direct connect methods. The issue would be that you're not sure exactly what the output is, but I don't know that that matters. You can make sure it sounds comfortable, and you can get some data after the patient is implanted. So localization testing and noise, localization testing. These are all important things that we need to do. Programming considerations, I think Meg Dillon, when she talked about it, is her audiologist, the audiologist she worked with, may have plugged the contralateral ear. I don't know how relevant, how important that is or not. I think every audiologist will have their own idea, but balancing comfort levels with the better ear we think is good. Obtaining accurate thresholds, of course. Objective measures is really very important. Data logging gives us an idea of whether the child's really wearing their device as much as they can. Psychosocial, educational, and rehab considerations. Consistent device use. Auditory training is critical. These kids and adults need rehab because they need the counseling that goes along with rehab. Behavioral and socialization issues with classmates, family, and peers. Again, we talked about pathologizing the child, labeling the child as a special needs child. We have to be very careful about that. We talked about the programming challenges, the plug and muff. As you can see, I talked about the hearing aid with an FM loop. This reminds me of a very funny story. One of our audiologists told me that she had a mother who wanted her to write in the IEP that they needed a plug and muff test. She thought the plug and muff test was a special test that should be in the child's IEP. So these are the kind of questions we ask, as you can see from this slide. And we have a lot of questions, and we don't have as many answers as we'd like. Again, we're looking at data logging. That's really very important for us when we're assessing the child's listening time. This is more about the children than the adults. So in terms of SSD candidacy, there are some absolute reasons to do on single-sided deafness. Adults and children that are likely to lose their hearing over time, a patient with EVA or other malformations, tumors. We have 2 adults who had sudden idiopathic sensorineural hearing loss, and you know that 10% of the time the patient will have an acoustic neuroma. They had MRIs, and there was an acoustic neuroma on the normal hearing side, which was incredible and a real serendipitous finding. And so these are patients that really are absolute candidates because they may lose their hearing in their better ear. Non-absolute candidates are candidates with stable situations. So summary and conclusions. Overall, early subjects are demonstrating that open set speech perception in the implanted ear is certainly a possibility, and there's a bilateral improvement in background noise. Subjectively, parents and schools report increased attention, improvement in grades. They're no longer asking what repeatedly, and they're no longer fearful of social situations such as the cafeteria and dealing with friends. So we think cochlear implants are a viable option for children with SSD and adults with SSD, although they do not occur without challenges. In terms of referral guidelines for ABIs and SSDs, I think audiologists who are just starting out or have limited experience, or their center has limited experience, should establish a relationship with a more mature local cochlear implant center and refer their patients, at least for ABIs, to those centers. And any good, mature cochlear implant center will be happy to talk to someone who is looking for answers, because there's a lot of, as I said, there's a lot of questions out there and maybe not as many answers. So thank you very much.